welcome back. I'm Mabel John. You're watching continuing coverage of the World Healthcare Congress here in Washington, D.C. Thank you so much for joining us, and a special welcome back to our folks who are watching us on their computers. Right now in our studio, we have Dr. Carl Couch, who is VP of Innovation at Baylor Scott and White Quality Alliance. He's based in Garland, Texas. Good afternoon.
Thank you. Good afternoon.
It's great to see you. Now, you work around data a lot. Is that right?
Yes.
What are the greatest challenges concerning the data in a clinically integrated network?
Well, my background is that I was the CEO and president of our accountable care organization at Baylor Scott and White until just this last year. And as such, as an accountable care organization, you've got to have data-driven performance as you take care of populations and as you do accountable care. It's based on the adage that if you can't measure it, you can't manage it. Right. And so all ACOs in the United States are very data-driven. Challenges that we have around data are many. One is challenges regarding the different sources of data that you've got to have. An accountable care organization has to have data from payers that reflects the cost of care, because that's the only true measurement of cost. They have to have data that's clinical, which mainly comes from our own electronic health record systems. And more recently, data coming from unusual sources like patient-generated data. The person that wears a Fitbit and his Fitbit data coming into our data systems. One of the challenges that we have is the data comes in different formats. It has to be aggregated into some kind of a warehouse that is able to produce meaningful information, because it's that information and those reports that drive our performance.
Is it becoming easier to collect data?
Data collection it's always been difficult. You can move data from one place to another. The problems are around the formatting of that data. Is it in a compatible format that we can read it? Is it, have we executed all the permissions that have to exist for data to flow from one place to another? Many of those are contractual permissions. Mm-hmm. Is the security of that data being protected adequately according to the national security standards that we all have to follow today to protect patient information, personal health information? And so it's not easy. It's a very complex process. The other is that very often the data is incomplete. There are problems regarding attribution of that data to one particular patient or another. Sometimes even the very data sources that generate that data are generating it in various different ways. For example, doctors working in the same electronic health record may input their information into that electronic health record in many different ways. One might enter a piece of data into a structured field, fill in the box. Another might dictate that same information into a text field. And how do you aggregate and pull all of that together? Because you want the same information, but so it's a very complex process.
What do you think needs to happen, Dr. Couch, to get this in a more into a system that is more consistent with how everybody wants to put it in to the same fields, to use the same language, to aggregate it and so forth? What still needs to happen?
Well, I think the answer to that's very complex. As some of our speakers earlier today talked about it, interoperability standards are going to be very important. Mm-hmm. We don't have good interoperability standards generated from our federal standards, from federal government standards. These are being worked on even today, but there's a great need to tighten up the requirement for interoperability, for one data system to be able to talk to another. So some of it has to do with national standards. Other things that I think will happen is I think patients will demand it, and I think your record as a patient is really your record. And I think patients will ultimately have some sort of ownership in that process as well, and that will help drive improvement in the data collection.
And who will drive this, do you
Well,
think?
I think
Who's taking leadership of this?
There is no national leader other than the government. And so I think we all have, in much of the evolution of electronic health records and all, it's been government driven. If you look at it, according to the PPACA legislation of 2009, that's what drove, and what meaningful use came out of that, and all of the other standards about data came out of the federal legislation. I think at the same time there have been industry innovators who have created improved ways of doing those sorts of things and collecting the data and creating interoperability that have improved that as well.
With all of the information that does exist, are the priorities set in the right way on how to use it?
I'm not sure I understand
In
your
terms
question.
of most meaningful insights and actions from that data, are those in the correct order?
If you think about it, we need data for two purposes. We need data for care, and we need data for improvement. Data for care means all of the information that I need about you and pertinent to your condition is available to me as a clinician as I treat you right at the point of care. So if you've ever had the experience, for example, of going to see a doctor and he or she says, well, I need your previous record from Dr. So-and-so, and you have to get that faxed in, or you have to go get it, pick it up yourself, or an x-ray report from elsewhere, and you had to integrate that data. It's cumbersome and doesn't work well. So if he or she is able to say, I've got all your data here, I've got all the information from your previous physician, I've got all the information from the x-ray that you had across town, and all of that is there, it's a much better experience for you. It's more likely to avoid making a mistake. If I can see all of the medications that someone else has given you at the point of when we're taking care of you, it's a much better experience. So data for care. The second is data for improvement, though. And that's sort of on both an organizational and a clinician level. So data for improvement means we have data so that we as an organization know that we're taking better care of diabetes, better care of heart failure, preventing readmissions on a numerical level, and it gives us an opportunity to know where we need to improve our processes to help improve that phenomenon. And so we got tons and tons of data in the world, but data that is meaningful and useful to help either improve your care or improve the way we do business and the way that we're taking care of a population is very, very important.
You have not spoken at this conference before, Dr. Couch,
I've not.
I understand. How are you finding the experience at the World Health Care
It's a
Congress?
very nice conference, well run, runs on time, good facilities, and good leadership. So I think it's a fine conference, and my fellow panelists and speakers, I've enjoyed listening to them as well. So.
Great. Well, we hope to have you back, Dr. Couch.
Thank you.
Thank you for your time.
My pleasure. Good to visit with you, Mabel. Thank you.
And thank you for watching. Please stay tuned. We have many more interviews to come.